Show you some slides. Okay. I believe you can see my slides now, yes?
Yes.
Okay, good. So that's what we're going to talk about. We're going to talk about what you and your family and others within the league and elsewhere would really need to know when they're facing the decision of how to personally maneuver around, navigate around Medicare and what is Medicare Advantage and such. So that's kind of what we'll be talking about. But I want to start with my favorite starting place, which is my excuse to look at my mother-in-law. Because if you raise your hand if you agree that that's like the most beautiful mother-in-law you've ever seen, and I can see you, so I want to see your hand. Okay, I didn't see hands going up, so I'm going to stop the conversation. No, okay. So that's my mother-in-law, and I'm going to tell you some things about her, and I have her permission to tell you this in case you're worried that I'm breaching confidentiality with her. Um, Ma passed away in April of this year, and the story of that process, I think, is pretty relevant to our discussion here. She lived in Daytona area, so near you guys, not far from you guys. And Ma had this pretty uncommon, actually rare cardiac condition that's genetic, not the usual sort of heart disease. She had a genetic one. For those of you clinicians out there, she had HOCM, which is pretty uncommon. And it's actually rare in somebody in her age, having this sort of cardiac disease when hers turned up when she was about 80, and having that happen is pretty rare. And she passed away at age 94. So, that she had something pretty good happen. So this turns out that being rare, there's literally no physician in Florida that has any focus or expertise on treating her kind of cardiac condition, and it's untreated. It's progressively fatal. So we looked around the country and found out that there's three places in the country that have expertise on this in someone in her age group, and one of them is here in St. Louis, where I live, at Washington University, is one of the three best places in the country for it. So we flew Ma from Florida to St. Louis, got her admitted, to the one of the world's best cardiology services for this problem. She got the interventions that she needed. Spent about 5 days, I think, in the hospital. Spent a few weeks recovering here at our house with us, and then went home. And like I said, that was 14, 15 years ago. And she, in the intervening time, had two orthopedic surgeries and a bunch of other stuff. And she would not have survived any of that. She was probably a month or two away from not surviving at all when this all developed. So, hooray, great outcome. And what does that have to do with any of you? Well, because she had Medicare. She had traditional Medicare. And let me explain what I mean by that, because what does that word even mean, traditional Medicare? So Medicare, as you know, was enacted in 1965. So the form of it that was created in 1965 is, in my mind, the traditional form of Medicare. Some folks call that original Medicare. That's a synonym. And as you know, Medicare, when it was created, had Part A for hospital stuff and Part B for outpatient stuff. So Part A and B. So when I'm saying traditional Medicare, I'm referring to that. Part A and B, inpatient and outpatient stuff, is originally created. And we'll draw some contrasts to that in a few minutes. She also had Medigap, which helped a lot, and we will explain that in a few minutes too. So anyway, she had that, and as a result of that, she could go to literally any place in the country. I think every hospital in the United States accepts traditional Medicare. 90 some percent of physicians across the country accept traditional Medicare. So she can go anywhere. And I'm the bloke who kind of managed all the logistics. That's what I do. I'm logistics. So I did that, and I'm here to tell you, I never called anybody to get permission. I didn't have to call anybody to get permission. It was just she could go where she wanted to. And because she had Medigap, she didn't have a penny out of pocket. She didn't have a single penny, no copay, no deductible. She didn't pay anything, little unusual, but she didn't pay a cent. And when she went home, she never got a bill. She never got a surprise bill. There wasn't, 6 months later, like so many of us have with employer-based insurance, 6 months later, or Medicare Advantage, you get a surprise bill, but she never got anything like that. And so she loved that. She viewed her red, white, and blue Medicare card as precious, and she trusted that it would be there for her for the rest of her life. And indeed, it was. So, and it was really helpful. But if you think about messing with her health insurance, you'd have to deal with this version of my mother-in-law, and I have, and you don't want to. So you don't want to do that. So what are we talking about? We're talking about traditional Medicare versus Medicare Advantage, and it's an important decision. But how important is the decision really? Well, at one level, it's not all that important what you're deciding because people in both groups, in traditional Medicare or Medicare Advantage, are pretty satisfied with most of their care. They're satisfied with care by their specialists, with the information they can get. They're generally satisfied with the quality of care. So why are we talking about this? Because there's more to the story than these kind of surveys would show you. So first thing to know is that if you're in the group of, most people don't know what I'm talking about. Most people don't know what the difference is between Medicare and Medicare Advantage. And you will, by the end of this, you will, but most people don't. Despite that, the vast majority of seniors don't want Medicare Advantage to be cut, even though they're not really generally aware of what it is. And that's not a partisan issue. That's true across party lines. So my goal is to help you be able to make a well-informed personal decision. So let's start with what is traditional Medicare. There's the precious red, white, and blue Medicare card, and it's almost, not quite, but almost as simple as my little cartoon is. We pay our taxes to the federal government. They mail us our.
Sorry. Cute. I'm trying to mute. Sorry.
Okay.
Sorry.
They mail us our little Medicare card, and then we use that and we go see doctors and hospitals, and the government then pays the doctor and hospital on our behalf. Almost this simply. Medicare Advantage is actually completely different. In fact, some folks would say that shouldn't even be able to be called Medicare. It is today. So some folks would say that's a misnomer, given how different it is. And to whom the advantage lies is not quite so clear. So it's a weird name, but there's Medicare Advantage in between the government and doctors and hospitals. So what basically happens is that we still pay our taxes, of course, and then the federal government does not pay doctors and hospitals on our behalf. Instead, they prepay the insurance companies. As you notice, similar insurance companies, many times the same insurance companies, as do employer-based insurance. So rather than Medicare paying doctors, Medicare pays the insurance companies, and then the insurance companies pay the doctors and hospitals on our behalf. So the first thing to notice, of course, is that they're prepaid per person, and it's their money at that point, and they're not eager to spend it. So they try to. They don't want to let go of that money. So there's this cartoon, which is a little bit more complicated than that because they actually tell you, you can't go to this doctor, you can't go to this hospital. We prefer you use that one, this one maybe. So it's quite a bit more complicated because of the way it's set up, and it's fundamentally different. Aside from being more complicated, probably the most striking thing is that you can't go to any doctor anywhere in the country. In fact, that was really important for my mother-in-law when she was in Florida and needing care outside of Florida. I don't think any Medicare Advantage company would have paid for her to get care in St. Louis. So that would have been a nightmare for us in many ways. And indeed, 12 million people in Medicare Advantage are in networks that exclude nearly 3 out of 4 of the doctors in their county. So if you go into Medicare Advantage, many times the physicians that you're used to seeing are not in the network anymore, whereas they were in traditional Medicare. So that's an important factor to consider. Also, Medicare Advantage, as I'll show you in a moment, unlike traditional Medicare, uses all the HMO stuff that we've known to grow and to know about and despise. So prior authorizations and such. It's because they're prepaid and they don't want to pay for your care generally if they don't have to. They prefer to attract healthier people who don't cost as much, even though they're paid for it. They have remarkable overhead and profits, and they average about 15% overhead and profits compared to 2% overhead for traditional Medicare. So a lot of what they're paid is going into their own coffers. And despite all of the things I'm saying, they're funded significantly more than is traditional Medicare. So the same person, if you turn one way and walk into Medicare Advantage, the insurance company will get 35% more to take care of you per month than had you turned the other way and stayed in traditional Medicare. So it's costing the country maybe upwards of $140 billion a year to fund this program over and above the actual care. So let's kind of contrast this a little bit more. First, in traditional Medicare, as I said, you can go to almost any doctor or hospital across the United States, but it's hardly perfect. The story doesn't stop there, or this would be an easy story, because traditional Medicare requires that you pay 20% of everything you get as an outpatient. They also require $1,600 for every hospitalization that you get. If you go to a doctor once a year, that's not that big a deal. But if you're sick and you need to be hospitalized 2, 3 times in the year, or go to a doctor not once a year but once a month, this stuff can bankrupt you, obviously. So it's expensive, and there's no limit to how high that can add up to. There's no limit in traditional Medicare to how high these copays and the hospital piece can add up to. So, I mean, literally, you're exposed to bankruptcy unless you're, not. It does not include some of the things that many of us think are really important. It does not include a pharmacy benefit. So most people in traditional Medicare buy a pharmacy benefit separately. Those average about $50 a month. So there's $600 a year. That does not include hearing or vision or any dentistry. And because of these limitations, most people, 90% of people in traditional Medicare have Medigap. And then that virtually eliminates these copays and deductibles. So what is Medigap? And I'm going to tell you about Plan G, G for good, because I think that's the one to get. There's a whole alphabet of these, A through N, I think. And if you're looking through them, just focus on G. That's, unless you really want to look deeper, but Medigap. So traditional Medicare is run, by the federal government through Medicare. Medigap is run through commercial insurance companies, separate and apart from Medicare itself. So Plan G is the example that I'm going to show you, and there are dozens of companies that sell this, but these are standardized. And so if you're shopping for a Medigap, I would tell you buy the cheapest. That's what I did, because they all do the exact same thing. So Medigap eliminates the copays and deductibles after you kick in 240. So you have to pay for Medigap, but then there's no more copay and deductible after you've hit $240 out of pocket. Really important protection to have if you're in traditional Medicare. But Medigap does not add hearing, vision, dentistry, pharmacy. It's just dealing with the copays and deductibles. So you're still having to deal with those issues with Medigap. They're not cheap, $175 a month on average, and that's probably more next year. I don't have next year's numbers in front of me. And so you're looking at, with Medigap and with Plan G, or a drug benefit, you're looking at what, $200 a month. That's $2,500 a year, roughly, to stay in traditional Medicare and have Medigap and have a drug benefit. And then that doesn't yet get you hearing, vision, or dentistry. So if you look at that, that's important. So a lot of people think that they'll just wait with going into Medigap and all that until they're sick enough to need to spend that kind of money. But the trick is that they're not guaranteed that they can do that. So the ACA, as you probably remember, eliminated pre-existing conditions. The ACA said that if you buy insurance through the ACA marketplaces, that the insurance company has to sell you a policy, and they have to sell it to you at the rate they charge anybody, and they can't ask you about your health. So we think, hooray, the ACA got rid of pre-existing conditions. It did for the ACA population, but it did not for Medicare. That rule that I just described to you does not apply to people in Medicare. So Medigap can give you a health survey questionnaire and can jack up your rate if you're sick, or can even refuse to sell you an insurance policy after you've been in Medicare for 6 months. The first 6 months that you're in Medicare Part B, as in boy, or the first 12 months that you're in Medicare Advantage, if you decide to go back to traditional Medicare, or you decide to purchase Medigap, the insurance companies have to sell you Medigap without asking you health survey type questions. But if you've been in Medicare Advantage for more than 12 months and you run into some of the concerns that I'm going to have you consider, and you decide, oh my God, he was right, and you're worried, know that you may or may not be able to purchase Medigap. There are 4 states, Florida's not one of them, that protects you and guarantees that you can purchase it, but you may not be able to. So we're looking at $2,500 a year to be in traditional Medicare and have Plan G and they have a drug benefit. So Medicare Advantage is attractive because it includes that pharmacy benefit and it often, almost always includes hearing, vision, and dentistry and stuff. There are copays and deductibles, but there is a limit to how high that can go, a limit of no more than $5,000 on average. Some have a much higher limit, make you carry a limit to as high as 12,000 or 13,000, but the most common Medicare Advantage plan limits your exposure to $5,000 a year on healthcare expenses as long as you stay in their network. Some don't cover you at all outside of network, some cover you less outside of network, but if you stay in network, you've limited your exposure to $5,000 without having to buy anything else. And I should have mentioned, although I didn't. The Medicare Advantage plans are very, very cheap. So the average Medicare Advantage policy can be purchased for $17 a month. In Missouri, it's free. Most Medicare Advantage plans are free. $17 a month is the average. So you're looking at, what's that, $200 a year, something like that, to go into Medicare Advantage. So that's often how the decision is for most people. I just said $2,500 a year for traditional plus Medigap and D, or now 200 to stay in Medicare Advantage. And it's kind of an easy decision for a lot of people who, for whom that's a lot of money. And the key message here is that they think that if they don't like the stuff that happens to them in Medicare Advantage, that they can go back to traditional Medicare and get Plan G. They might not be able to, as I sort of beaten to the ground a couple times. Then the last thing about Medicare Advantage to finish this comparison is that in theory, legally, Medicare Advantage companies are required to cover the exact same range of benefits that are in traditional Medicare, plus the extra stuff, the hearing, vision, dentistry, and pharmacy. So they're legally required to cover the exact same things. And they will tell you that, right? They will say, hey, we cover the exact same stuff in traditional Medicare plus more. But what they don't tell you is that they are legally allowed to determine whether what you're trying to get is medically necessary or not. So they can decide, oh, that rehab, you only needed 2 days, you don't need a month. Oh, that whatever that, that traditional Medicare would have covered, the Medicare Advantage companies that are prepaid and don't want to pay for it are allowed to use their own proprietary criteria that are not disclosed even to Medicare. Nobody knows what those criteria are. And based on those secret criteria, block access. So there's kind of a trade-off here. Traditional Medicare, you can go to almost any doctor in the country. Traditional Medicare, you kind of need to get Medigap if you're careful, but you might or might not be able to. And then Medicare Advantage doesn't have those kinds of issues, but they can block you from getting care. They're allowed to. So traditional Medicare, almost any doctor, no limit on out-of-pocket expenses. Combine that with unaffordable premiums for many people for Medigap, and you wind up with many people having no real choice other than Medicare Advantage. And then, as I said, once you're in there, not being able to afford to leave. So I want to make sure you understand the decision that you're making. I'm going to skip that. Sorry. So in theory, they cover everything. Medicare Advantage covers everything, and in practice, most that's covered by traditional Medicare, and in practice, they cover a whole bunch of other stuff. So they all cover a pharmacy benefit. They all, just about all now, cover eyeglasses. They cover dentistry and this whole range of stuff. And there's another 10 things or so that most of them, many of them will cover. So there are extra benefits for being in Medicare Advantage. They're not as robust as they look. Like dental, let's just unpack that one. My father was a dentist, so I'm interested in that one. So dental. So a lot of people, actually value access to dentistry more than they do access to a physician. So it's a really important piece, dental care, and it's very attractive to talk about having one. Turns out the dental benefit in Medicare Advantage is pretty pretty crummy. It's pretty crummy. So if you just look at what people pay out of pocket in traditional Medicare per year, it's $26 more per year than Medicare Advantage. Medicare Advantage saves you across the board saves you about $26 a year on dentistry if you look on average. So how can that be? People in traditional Medicare don't have dental insurance generally. Maybe they do, but people in Medicare Advantage, all they do. How can this be? And it's not because they have insurance on the traditional side. The total expenditure is about the same. So the one reason is because Medicare Advantage has very, very limited networks of physicians, and so typically people in Medicare Advantage with a dental benefit still go outside of the network and pay for it. And the benefit itself stops at about $1,000 a year in the majority of cases. Some dental benefits go up to 4,000, but most of them stop at about $1,000 a year and require you to pony up quite a bit of it. So people are still not getting the care that they need. And they have waiting periods. If you have an abscess, they may make you wait 6 months or 2 years for care. And the range of things that they cover varies by insurance company. Hard to get this information. So the point of this little rabbit hole I dragged you down into is that the dental benefit is not like many of the other perks are not nearly as generous as you might have thought at first. And that reminds me of the next problem or concern is they're requiring permission to get care. So my wife, and I have her permission to tell you this story, my wife needed what's called a high resolution CAT scan of her chest. She had this thing. I know not to worry. I don't treat my wife. I'm not stupid like that. And she needed this CAT scan of her chest according to her physician. So, okay, I'm logistics. I called the radiology suite and said, hey, I need to schedule this CAT scan for my wife. The first question that they asked me was, what's her insurance? First question they asked me, what's her insurance? They didn't ask me her name. They didn't ask me her diagnosis. They said, what's her insurance? And I said, well, we have traditional Medicare Part A and B, and we have a Plan G Medicare supplemental policy. I knew all those words. And then their answer was, well, what time tomorrow would you like to come in? I went, when? That's how this is supposed to work. Yes. So we scheduled the appointment. And then when we got it all locked in, not before, not, when we got it locked in, I said, so, why did you ask me that? What would you have done? How would you have used the answer to that question? And they said, well, if you had said Medicare Advantage, we would have told you we'll call you back in a week or two because we have to wait for approval from those companies. So, I'll bet some of you have been through this kind of a thing where your doctor tells you need to get a test. And it's not usually because you're feeling great and they want to give you a Christmas present. It's usually because something's wrong that you and your physician are worried about. And that time waiting to move things forward is terrifying. It's terrifying. So, and it actually can kill people, as I'm going to show you. But, this is not a small problem when they make you wait to get approval for things. And that was the standard here. Turns out they make you wait for approval for almost everything. That's expensive. So here's the range of things. If you want to get a wheelchair, they almost all require that. Part B drugs, infusions for cancer in your oncologist's office or in your rheumatologist's office. Part B drugs are the ones that get infused someplace. They all want their chance to say no and to weigh in on this. All these things are things that require approvals from people. It turns out that almost all the people appeal these decisions. And it turns out if you appeal a decision in Medicare Advantage, a denial in Medicare Advantage, chances are you will get to a yes. So if Medicare Advantage denies you something that you think Medicare would have covered, appeal it. Appeal it. That's not easy. That takes time. You need your physician's collaboration on it, but do the appeal if you get denied by Medicare Advantage, because the overwhelming majority of time you'll get to a yes and they will cover it. That's because they're not denying you because you clinically don't need the thing. They're not denying you because it's something that's just not covered as a benefit by Medicare. No, they're denying you because remember, they're prepaid and they don't want to pay for something expensive like this stuff. So if you go through the appeals process, and most don't, because who wants to, but if you go through the appeals process, the vast majority will get to a yes. So that's a good thing to know if you're in Medicare Advantage and can't afford to get out. Traditional Medicare is completely different. They almost never do these prior authorizations. They have three specific areas that they do prior authorizations for. If you appeal a denial in traditional Medicare, you will very likely lose because they will only deny you care if it's not a covered benefit. If it's not a covered benefit, they're not going to second guess, your needs for things. They don't do that. So you may know something, so that they don't know. So if you really think you know something important that they don't know, then do the appeal. But in general, traditional Medicare, if they appeal, it's not because of business interests, it's because of what statutorily is required for them to pay for. So this adds up to people in traditional Medicare, in Medicare Advantage, receiving less care on all these things because of these delays in care and denials in care. If you compare people in Medicare Advantage to traditional Medicare, they get 5% fewer speech therapy visits. They get 5% fewer home health visits. They get less nursing visits. They get less of pretty much everything because the insurance companies like it that way, and they're legally allowed to do this, which means that people have trouble affording care. So across the board, people in Medicare Advantage are much more likely to say they have cost-related problems accessing care. And welcome to America. It's worse if you're in a minority group, but people of color have even more of this problem. But white people have this problem pretty significantly too with Medicare Advantage versus traditional Medicare. And likewise, medical bills and debts. People in traditional Medicare are much less likely to have medical bills and medical debts. Low-income people, because often them they have Medicaid along with it, aren't quite as badly hit between Medicare versus Medicare Advantage, but those numbers are just obscene to begin with. Medium income people, middle income people, that's the group that has the biggest discrepancy between Medicare Advantage and traditional Medicare in terms of being able to get care. And if you're wealthy, well, guess what? You don't have this problem nearly as much. But these problems aren't just inexpensive, or expenses and inconvenience. The problems actually, well, they kill us. So let me tell you about my buddy, Lefty. And this was not Medicare Advantage. He was 64 and a half when this problem started. He had esophageal cancer, which that's not something that, that's one of the more tricky things to treat. And it tends to be, it's very few people do well. Some do, but very few people do well with it. So if you have something dreadful like that, you want to make sure you're going to one of the best physicians in the country for that. You really want to. Lefty lived in rural Missouri, and there's some docs in his community that would treat him, and they did the best they could, but his insurance would not let him come to Washington University, Barnes Jewish here in St. Louis, where we have tertiary care specialists who treat this. And he was very frustrated for the first 6 months, and he said when he recovered from this, he wanted to go on a speaking circuit with me because he's heard me blather on, and he wanted to have it called "I Got the Keys to the Kingdom" when he gets into Medicare. Because remember, he was 64 and a half when this turned up, and his insurance company, not Medicare Advantage because he wasn't quite old enough yet, but Medicare Advantage does the same thing, wouldn't let him come here. And then he got 65 years old, and he joined Medicare, and like immediately, he received superior tertiary care. And as I said, he liked to put it like that, I got the keys to the kingdom. But, 6 months is is a big deal for many cancers. 6 months is a big deal. And indeed, by the time he got into a tertiary care center, there was really zero hope. And so in my mind, his insurance company, has delayed his care to the point of contributing to his death. Lefties is not a one-off story. Lefties is actually a typical story. So if you look at cancer patients in Medicare Advantage, about being treated, the gap between diagnosis and treatment, it turns out that they have significantly more delays in getting into treatment once they're diagnosed. People in Medicare Advantage have delays from diagnosis to treatment in many cancers. And they don't get to go to the best places like Lefty ran into. You don't get to go to the tertiary care centers despite wanting to. So people in traditional Medicare don't all want to go to a tertiary care center. They're far away from home. Not everybody wants to do that. But that should be your choice. There shouldn't be an insurance company saying, no, you can't use the best. That shouldn't be the case. How important is this? How important is delaying care and not going to the most experienced places? Was Lefties a one-off story, or how important is this? Well, it turns out it's really important. It turns out that because of those two things, people with cancer are more likely to die than are people in traditional Medicare. People with cancer in Medicare Advantage have higher death rates than do people in traditional Medicare. So it's a big deal. So where do you learn this stuff? Where do you learn about this stuff? Well, it's all over the place, right? I mean, you can go to an insurance broker, and just here's one ad that I found a few weeks ago where they tell you straight up that they are unbiased licensed agents, and they will give you the straight poop, and they'll tell you. I've had many of them say to me, "Well, I sell all the insurances. I'm not biased. I'll sit and talk with people, and I'll figure out what's best for them." And then I'll get them sign up for the policy that's the best for them. I sell everything and it doesn't matter to me what they buy. Turns out that's wrong on two levels. First, they lie to you. Medicare did secret shopper calls a couple of years ago to these agents, and 80% of the time they were either lied to or given insufficient. They're either given inaccurate or insufficient information. And my favorite is this one. If your drug's not on the formulary, don't worry. Your doctor can just tell the Medicare Advantage company and they'll just add it. So here you've done the hard work, you've sat down, you figured out whether your drug's on the formulary, and you tell this as a concern to your insurance agent, and they say things like, not to worry, calm down. They'll just put it back on for you. Like that makes any sense. But they say stuff. This isn't a Senate, this is CMS, Medicare, found this. And the reason for these things is because they are not unbiased, no matter what they might tell you, they're not unbiased. And matter of fact, next year, and this is just a little bit, these numbers are just a little bit larger than this year. Next year, if an insurance agent sells you Medicare Advantage, they'll make $600 for that sale. They'll only make $350 if they sign you up for Medigap. And Part D, good luck finding an insurance agent who will talk you through Part D because they don't make much on that. They'll tell you, oh, just go to the Medicare.gov. You can do that on your own. It's really easy. It's actually harder to do Part D than it is to do Medigap or Medicare Advantage. So no, it's just, they're making $600 versus $350. So tell me that they're not interested. And that's just year one. If you stay with them, if you don't change to a different broker, they get it's the gift that keeps giving. They'll make another $300 every year that you stay with them for many, many years. So, my agent that I talk to, because he's a buddy of mine, he'll call me up once a year and say, "Hey, we haven't gotten that burger. We're due for burgers." And then we've renewed, and it probably would have renewed automatically anyway. But how important are these biases? It's the business model of the insurance agents. So I went and found this outfit that trains insurance agents about Medicare stuff. And this is a direct quote from their website about 2 months ago. One of their top marketing specialists. This talking to the insurance agent, if you want to retire on your renewals, it's not life insurance. You got to be in the Medicare business. You got to be in the Medicare business, and it's big money. If you retire as an insurance agent with 100 people on your books, you're going to be earning $30,000 a year in retirement for nothing, for doing nothing. If you have 500 clients, and some of them do, you'll retire with $150,000 a year just from Medicare sales. That's Medicare Advantage. So when an insurance broker tells you that they're unbiased and that they sell everything, they are misrepresenting the facts to you. So what do you do? What do you do? I'll give you two places you can go. And one of them is actually in the room with you, as I understand it. So Shine. So hooray for Shine. There's a QR code that if you have a camera, you can point it to the little camera screen here. Shine. So what is this thing? So this is a national arrangement. The federal government funds what are called state health insurance advisors, something like that, SHIP program, state health insurance. Sorry. They fund these in all 50 states. Every state calls them something a little bit different. The one in Florida is called Florida Shine. That's kind of cute. And what these are is they're funded to run them, but then almost everybody working there is a volunteer. So they're full of volunteers, and their volunteers are sign a confidential or a non-disclosure, a non-conflict of interest thing, so that they're not like working for the insurance agencies. They're not, they don't have any conflicts of interest. So you can trust what they say. They're volunteers, and most of them, in my experience, are like great at this. They're volunteers, and they're not all, but most of them are great. They're unbiased, but Medicare itself requires them to give sort of an even balance between Medicare Advantage and traditional Medicare. And as I think you've seen in the last half hour, there's some stuff here that you might want to know that the Shine folks are just like not allowed to really talk much about. But they're generally, great. So you can go to their website. And you can do this elsewhere if you have family elsewhere in the country. Go to shiphelp.org. You can find the ones around the country. You can set up an appointment to go in and actually meet with them in person. So if you like to go and meet in person, this is the group. Hook up with the Shine people that are in your room right now when I get through talking to you. Or you can go to Medicare.gov. Just go online to Medicare.gov. Any other website is not Medicare. So go to Medicare.gov, not MedicareHelp.gov, not MedicareBananas.gov, Medicare.gov, or call them at 1-800-Medicare. 1-800-Medicare. I have called them many times, and I'm here to tell you they're terrific. They're terrific. They give you they answer quickly in my experience. They're friendly on the phone. They're well informed. They answer almost all my questions. If they don't answer a question, they can get somebody else who can answer the question. But do recognize that there's a lot of people working at that phone number, and so every once in a while you'll call and you'll get somebody who's just like not understanding you, or they're giving you answers that don't make sense. So if that happens, it does happen sometimes. Just be polite. These folks are working hard. Be polite. Say thanks very much. Appreciate it. Hang up. Call right back, and you'll have a different agent, and you'll probably then have the kind of great experiences that I've been describing. So Medicare.gov, you can compare website, you can compare all the plan options, you can compare all of this stuff, you can compare all the Medicare Advantage choices. They're all on there, spelled out. So I recommend, going there or setting up a moment to meet with Shine folks. Last thing, and then I'll stop blathering at you, is my organization, Physicians for a National Health Program. We also have this website we built called healmedicare.org. And it's got more information, more background, more talks like what I'm doing for you right now. You can do a few things. There's the QR code that you can get to at healmedicare.gov. We have a survey because we would like to know what your experience with Medicare has been. So if you're in Medicare, we would appreciate your taking that survey. Go to healmedicare.org, take the survey. If you have concerns about the issues, which I'm sort of hinting at, we have a petition to try to address that. And then lastly, if you could, if you think of it, bring this website to your next physician visit and ask your physician to fill out the survey that we're doing on physicians as well. So that is my blathering.
Thank you so much. That was amazing. All right. There. I knew that there were going to be hands up right away. So let's go ahead. We'll try to go back and forth between chat if there are any questions in the chat, but go ahead.
Yeah.
You either that or if you
Can
will.
you hear me, Dr. Watson?
Barely. I can, but barely.
Yeah, come on up here.
Quick question. You went quickly at the beginning. You were talking about bouncing between Medicare Advantage and Medicare, and that if you're on it for 6 months, can you run back over that? Because that flew past me. I didn't quite get all of that.
Yeah, I know. Thank you. It's among the most important things to know when you're making this decision. So I'm glad you asked me that. So can you go back and forth between Medicare Advantage and traditional Medicare? Well, once a year, you can go from traditional Medicare into Medicare Advantage. So you have a window to do that every year. Medicare Advantage, once a year, you can also go back. You can leave. Anybody can leave Medicare Advantage once a year during open enrollment, which we're in the midst of right now. So you can always leave Medicare Advantage during open enrollment and go back into traditional Medicare. And you can actually do that the first 3 months of the year too. So between now and I think March something, you can say, oh, I heard this talk, I'm afraid of it, I don't like it, or whatever. You can if you can afford Medigap, you can always every year in the next 20 years, who knows, but you can always switch back from Medicare Advantage to traditional Medicare. The problem is if you're in traditional Medicare, you really want to have Medigap. You really want to have Medigap because traditional Medicare has these copays and deductibles that are, bankruptcyville if you're not, protected. So Medigap makes that go away. Plan G, as I was saying, averages about $175 a month. You should know that there is a high deductible Plan G that has, I think, a $2,000 or $3,000 deductible. I forget what that is. So if you want to go back into traditional Medicare and the $175 Plan G supplement is prohibitive to you, look at the pricing for the high deductible Plan G. So, there is that. But the point I was trying to make, which I still have not yet made, despite you asking me that very specifically, the point I was trying to make was that there's no guarantee that you can buy Medigap. There's no guarantee that you can buy Medigap. The insurance companies that sell Medigap are required to sell you Medigap the first 6 months that you're in traditional Medicare or the first 12 months that you're in Medicare Advantage. So if you're in Medicare Advantage for 11 months and you decide, I want to go to Mayo and they won't let me, you can switch back to traditional Medicare and you're guaranteed that a Medigap insurance company has to sell you a policy without asking you about your health. So you're guaranteed the first 12 months that you're in Medicare Advantage, if you decide to flip back to traditional Medicare, you're guaranteed that you can buy Medigap and you're guaranteed that they'll charge you the same as they would anybody who was healthy. So that's good. But if you're in Medicare Advantage for 13 months and you run into one of these problems and you decide you want to go back to traditional Medicare and buy Medigap, you might be able to. I mean, you might be able to. They still might sell it to you, or you're healthy and you decide you don't want it. You might be able to, but they can and usually do send you a survey asking about your health. Do you have diabetes? Do you have blood pressure? Do you have cancer? Do you have anything? Do you have acne? I mean, they can ask you anything, and based on your results, they can arbitrarily decide, we're not going to sell this person a policy at any price, or the price we're going to charge them isn't $175. You're going to have to pay $900 if you want to buy Medigap. They can do that. So the first 12 months that you're in Medicare Advantage, you can leave, you can go back to traditional Medicare, and you're guaranteed that you can buy Medigap. After 12 months, there is no such guarantee. You can always leave, you can always go back to traditional Medicare, but there's no guarantee that you can buy Medigap at that point. Did I answer your question? It's ridiculous that we have to know these things. I mean, if I could change hats for just a moment and tell you, I think the real answer is we should just all have healthcare that we don't have to ever think about. Just covers everything and forget about it. But we're not in that world. We're in this world. So
We have a
Well,
question in the chat, I think.
yes, hold on. We have a question in the chat and then we'll call on you. Ronnie Luffler wants to know if you want to keep the same plan, do they have to do anything or does it roll over? My comment is to endorse the work of Shine, which has helped her a lot. I mean, so that's a big deal. We know that. And then another person has asked about surgeries, and then we'll go to the in-person, if that would be all right with you.
sure. So if they default you into the same thing that you're in, or something as close to the same as what you're in. So generally, if you're in Medicare Advantage or in Medigap and you don't do anything, or you'll automatically be kept in that program. And if that program for some reason disappears, Medicare will pop you into something very, very similar if the exact same thing doesn't exist. So the default is that you'll stay in. So that's one. Somebody asked about surgeries too. You said, and surgery. I was just saying medicine, but yeah, surgery is the exact same. There's nothing different about surgery. They have the narrow networks of surgeons and hospitals, and they can prior approve you for surgeries or not prior approve you for surgeries, and so the same exact issues apply to surgical things. And when they ask you your health survey questionnaire, they will be asking you about surgeries and all that happy stuff. So yeah, it's the same. And I double down on saying how good Shine is, so,
I will also say that I read someplace that the prices for 2025 for Part D have gone up. So it's a good idea, even if you like what you have, to at least check it out, because I've heard that there's an increase in the co-pays and stuff like that. That's just a thing I read the other day. So
it's interesting. That's an unintended consequence. So one thing that's changing in 2025 is that there's a new lower out-of-pocket maximum in drug plans. So there were these donut holes and this, many thousands of dollars that you could have to pony up in Part D. And then the Inflation Reduction Act introduced a $2,000 maximum out of pocket if you take a formulary drug. So non-formulary, you're still, on your own. But if you're taking a formulary drug, the most you could have to spend out of pocket is $2,000. Well, who pays for the stuff above $2,000? The insurance company, right? I mean, the insurance company does. So because of that good $2,000 out-of-pocket maximum, Part D plans would struggle. So some of them have raised premiums, some of them have raised co-pays and stuff. But Medicare, sometime early summer, started what they call a demonstration project, where they're actually Medicare is funding the drug plans more generously than they were until this summer, the demonstration project. And because of that funding, if they accept the funding, and I think they all did, they can't raise your premium for Part D any higher than $35 above what they're currently charging. So many of the plans are increasing premiums up to or just shy of $35 more per month. Had they not done this demonstration project, would have gone up a lot more than that. But the reason I'm unpacking that kind of detail is that that's one of the things that the incoming presidential administration is talking about disassembling. So those supplements so we may see in 2026, if the incoming administration does reverse that demonstration project, 2026, we may see the Part D plan premiums go up much higher. And right, as Candy was saying, that puts more pressure on the decision of, can I afford to buy Medigap? Can I afford to buy the supplemental policy? Can I afford to buy the Part D benefit? Because Medicare Advantage plans are not raising their price despite having the same constraint. Despite having to also deal with the $2,000 out-of-pocket maximum, they're not changing their price much. Instead, the Medicare Advantage companies aren't changing the most visible piece of premiums very much, but they are getting more rigid on their hospital networks, more rigid on their prior authorizations, higher copays across the board. So the same problems are going to be affecting Medicare Advantage, but since it's a whole insurance company and it's not just the pharmacy benefit, they're able to hide that more. And so the expectation is that as Part D premiums go up, that's going to make it even harder for people to afford to be in traditional Medicare. And again, a long answer to a short question.
Go ahead.
I think you've sort of answered one part of my question about once you're in and have a Medigap plan, can they never answer the questions? Or if the company goes out that you said Medicare will put you into somebody else, are you then subject to, at some point down the line, having to deal with that? And then the other part was, which 4 states don't have the pre-existing?
I didn't hear that last thing. What was the last thing you said?
Which states have guaranteed issue? So which are the 4 states?
Yeah, I'll do that one first. So the 4 states that guarantee your issue are New York, Massachusetts, Maine, and Connecticut. But it's not a slam dunk that we should do that. New York, Massachusetts, Maine, and Connecticut. It's not a slam dunk that and so the other states have little bits of this, but nothing as robust. But the reason I say it's not a slam dunk that we should just solve the problem that way is because those 4 states actually have significantly higher Medigap premiums, right? Because they have to cover guaranteed issue. And they actually have higher Medicare Advantage adoption because people know they can always get out and buy Medigap. So it turns out that fighting for guaranteed issue and community rating in other states beyond those 4, that's a fool's errand. I wouldn't do that. But the first thing that you asked about, if the Medigap company changes, are you then subject? No, you're not subject to health survey questionnaires. Once you're in Medigap, as long as you stay there, if you take a break, you're screwed. But as long as you stay in that Medigap plan or something similar, there may be some nuance to that I'm not sure of. But once you get into Medigap, they cannot send you the health survey questionnaires and stuff later on. Once you're in, you're golden. So you want to stay there once you're in.
If you do one of those high deductible ones you said, and then decide you need to switch once it's later down the line.
You're asking if somebody joins a high deductible plan G and then decides to switch from the high deductible to the regular plan G, are you then subject to underwriting? And I believe we have people in the room who are more expert at that question than I am. It's a really interesting question. So I would hope one of the shine people can answer that. I cannot.
Okay.
Ask me again in a week and I
Yes.
won't answer.
Yes,
My husband and I had a Medigap plan, and then one year my husband got on an Advantage plan and fell off a ladder and had a serious fracture. And when I called his insurance company, it seemed like it was going to cost us quite a bit for him to be hospitalized and have the surgery, which I didn't realize that they could do that. And so he went with workman's comp, which created other issues. But so can they charge you all sorts of things once you use their services?
Yes. There's a limit to how high that can go.
Yeah.
So if you're staying in network with the Medicare Advantage company, when you going to their hospital that they want you to use and using their orthopedic surgeon they want you to use, if you're staying in network, there's a limit. I believe the statutory limit is $9,000 per year, but most Medicare Advantage companies on average have a limit of $5,000 a year. If you go outside of network, the statutory limit is as high as $13,000, and most have a realistic limit of about $7,000 or $8,000. So how do they get to that $5,000 or $8,000? Any way they want, any way they want. So they can charge you like, a crazy amount for hospitals or for physician visits. They get to decide the copay and deductible structure. Sometimes they make it zero. Some of them will say you can go to primary care docs for free. Some do that, but they typically make the expensive stuff expensive for you too. So yes, what you ran into is entirely legit.
Thank you.
If you had traditional Medicare and Medigap, that wouldn't be an issue. But like you said, you can't always do that.
yes, ma'am, go ahead.
So, just to reinforce what you said, when I went on Medicare, someone had recommended an advisor. And after talking to him, I thought, I don't think this is right. I think he's giving me a sales job. And so I got another recommendation, and went to another person. And my first question to him is, listening to what this guy said, I don't see why anyone would go with Medicare and Medigap. So why would I do that? And so he explained kind of what you have explained. The problem was they were both just recommendations. I think I got lucky by getting the second guy, and I know everything that you're saying there because he educated me. And so I don't know exactly, like you say, except for going to like Shine. It's really hard to be discerning about the information, and it's complicated. So
A third of seniors rely on an insurance broker to make their decision. That's not the greatest solution. A third rely on well, actually, I don't remember the rest of the numbers, so I won't tell you. But I know a third rely on on an insurance broker, and it shouldn't be like that. They shouldn't be able to do that. And we know the problem. We shouldn't be able to do that.
I'm going to call on Ronnie. I'm going to hope that we can hear you, Ronnie.
Okay, do you hear me? I'm speaking now.
Yep.
Hey,
Wonderful.
good.
Well, first I wanted to share just some information for people who are using Plan D. There is one plan that has no monthly payment, which is it depends on your needs, of course, but it's WellCare and there's no monthly charge on it. All the other limitations on the $2,000, et cetera, still apply, but there is no monthly fee. Of course, whether you choose that will depend on whether the drugs you need are covered or how they're covered, what the cost is. But it works for me. Just like for me, I'm on, actually, I was grandfathered into Plan F, and I really consider myself fortunate. And I I got my counsel from Shine and I am forever grateful. And I went back a few years in a row because I kept thinking, oh God, this Medicare Advantage costs nothing. It costs nothing. It costs nothing. And I'm going to just tell you what the Shine counselor said to me. He said, well, you get car insurance every year. And at the end of the year, if you didn't crash, you say, darn, I didn't use my insurance. Let me go run into a tree now. And and that's exactly it. I mean, I'm happy I pay a small fortune for my traditional Medicare and the Medigap, but it's paid off for me. I fell 2 years ago. I was able to be in rehab for 2 months. I'm still able to get PT. I don't need prior authorization. And so, yes, I pay a lot, but what I was told again by Shine, if you can afford traditional, go that route. If money's an issue and you can't, Medicare Advantage is better than nothing. But now I have just one question. So, why is Medicare Advantage able to offer benefits like free food and free gym membership and things like that, which are enticing to people? And I pay for my own food and I pay for my own gym. Why can't that be offered as part of traditional Medicare? Do you have any idea?
I do. I do know the answer to this question. Um, and I mean, the root issue is because we have a screwed up democracy.
Well,
That's the root
okay.
issue. But more. What do you do about that? That's a
That's
different.
another story.
Come back next month. We'll have that discussion. But the reason they're able to afford to do that is because they have a whole series of games, and they've rigged the system so that they are paid, as I said, on at least 22% more per person, and we think maybe as high as 35% more per person. So, that extra payment that they get almost all goes into their overhead because there is a lot of overhead, 15%. But they are with that, they're able to to use that extra payment to give these extra benefits, hearing, vision, dental, and such. But the because they've negotiated to make so they pick the benefits that they provide in my experience, in my judgment, the benefits that they're giving as extras, hearing, vision, dental, gym clubs, those are things that are most attractive to healthy people, right? Somebody that's got, somebody on a with end-stage emphysema, they're not looking at going to a health club. They're not as focused on I need my new glasses. They're not, they're not. So the people that are really, really sick tend not to be as attracted by those extra benefits and instead are really discouraged by the barriers to care. And so the really, really sick folks are the ones who most try to get back and are the most trapped. So there's a lot of work being done to try to get traditional Medicare able to offer similar benefits as what you described. We were actually really close to having a bill submitted that would have done that. The new election has kind of changed the balance of power on those kinds of improvements. But so that's been changed. One thing I want to sort of sidetrack into, you mentioned Plan F. And I want to make sure that there's probably others in the room that are on Plan F, and I want to make sure you all know one particular thing to watch for, which is F, by the way, in my mind, F stands for fabulous. It's the best plan. It has no copays and no deductibles. So it is better than G that has the $240 deductible. So F is better than Plan G. But they no longer sell Plan F. The government has closed Plan F. The people that think you need some skin in the game won that fight, and they got Plan F to be taken off of the market. But the compromise was they wouldn't kick people out of it. So if you're in Plan F, hooray, you have really the best supplement. The thing to know about that, though, and to think about, is that because they don't sell it anymore, the people that are in Plan F are every year getting a year older. And so the people that are in Plan F are every year getting a little bit sicker, a little bit more expensive. So what we're going to be seeing is the premiums for Plan F rising more rapidly than the premiums for Plan G. So at some point, it's just something every year, if you're in Plan F, you want to kind of go back and look and see what are they doing to your premium? What would the premium be if you went into Plan G? And make a new business case decision. And I would leave it to the Shine experts to tell us if that then means you're vulnerable to pre-existing conditions again, because I don't know. It was a really interesting question somebody asked. But so keep an eye on it. Your Plan F might become increasingly expensive over the next few years.
It already is. It goes up, seems to go up about 5% a year, 4 or 5%. But so far, the trade-off is worth it to me. I would probably change if I could go back to it, but I know I'll never get back into it again because now I have pre-existing conditions. Comes with
I'm
age.
sorry.
Go ahead.
For the insurance companies, through the Medicare Advantage plans, is there a cap on their profit? So can they earn more than 15%? I mean, do they have, what is it called, a medical ratio, loss ratio, or are they tied to that?
No.
Did you hear that question?
Yeah,
No.
the answer is a resounding, emphatic, bold neon colors. No, they don't have that. That was something introduced by the Affordable Care Act. It does not apply to Medicare Advantage companies. Does not apply to them. They the way that their payments are structured is fairly complicated. I'd be glad to walk you through that. But the way that their payments are structured, there's at least four, if not five or six, sort of major opportunities for them to game how much the federal government. Let me give you one little example. So they're prepaid based on the average person, what it costs the average person in the county that they're in. They get prepaid that amount. And then that gets adjusted to a higher prepayment if they can demonstrate that the people that they've enrolled are sicker than the average person in that county. So that creates, how do you determine somebody's sicker? How many diagnoses do they have? So they have a business model with all sorts of infrastructure and all sorts of stuff designed to rack up extra diagnoses on people that are not being recorded in traditional Medicare because nobody's making money off of adding more diagnoses. So Medicare Advantage, it's called upcoding, where they add a whole bunch of diagnoses. They send a nurse out to your house to, look nice, but then to say, oh, you've got such and such, and they add diagnoses that your physician doesn't think is relevant to the care that you're getting and doesn't add in. But the Medicare Advantage corporations add those diagnoses in, and as a result, instead of being paid this much, they're paid this much to take care of you, despite the fact that that's really kind of fake. It's not really real. So they have ways of getting their capitation. There's other gambits too. There are ways to get their capitation jacked up. Like I said, 22 to 35% above what they should be getting if it were fair. And that adds up to maybe as much as $140 billion a year. They have ways to do that. And then they can block your care. Like I said, they can keep you from going to the expensive places. They can keep you from getting care at all. They can delay and deny and redirect you. So at the end of that, they have all these gambits to focus on their own profits, which they're very successful at. And there is no limit on their profits. There is no in general insurance through the marketplace. There's a maximum 85% of what a regular an employer-based insurer, 85% of what an employer-based insurer collects in premiums has to go into medical care. 80% has to go into medical care if it's a small group, but there's a limit. That's called the medical loss ratio, and that's 80 to 85% in pre-Medicare insurance type stuff. But in Medicare, those numbers don't apply at all. That doesn't apply at all. That's just not even a concept there. They don't even report medical loss ratios.
Yeah, go ahead.
Is AARP truly an advocate for the aging community? They are run through United Healthcare here in Florida, so I assume, yeah, I assume it's AARP United Healthcare here. Are they truly advocating for us?
In many ways, AARP does a whole lot of good in many ways. On health insurance, to me, it's a much more confusing bag where they have significantly conflicted interests. They sell both Medigap and Medicare Advantage. They don't sell any of this stuff. They co-brand with United Healthcare. So they let United Healthcare use their name. But I don't believe AARP itself actually runs the insurance, but they co-brand United Healthcare's products all over the country. That's not unique to Florida. That's everywhere. So since they're in the same sort of situation as the insurance brokers are, as I was alluding to, where they make money off of that, it's hard for me to see that that's not a very conflicted interest in working against the best interests necessarily of their members. So whether they're advocating for seniors on this issue is not as clear to me. I wouldn't jump to say yes, but I also don't want to trash AARP because I think there is a whole lot of value that they bring in other areas, just not this one. They're pretty conflicted. Notice how I'm saying this because I know you're recording my answers. So read between the lines as much as you want.
Yes, sir.
The change from the an Advantage plan to Medigap. I understand that there's medical review. Is there anybody on the outside that knows what the Medigap insurance companies will reject?
What they will, you're asking how often do Medigap insurance companies actually reject people signing up for them?
No, but what I'm asking is, do they reject a patient that is sick all the time?
There is wide variation on this. There is wide variation on this. They each can have their own policy on this. So we know that you're not guaranteed getting Medigap after 12 months in Medicare Advantage. But I did say shop around because you might be able to find one that will sell you a policy at an affordable price. They're all different. They're all different. So if you're in Medicare Advantage and you're thinking of going back to traditional Medicare and wanting to buy Medigap, I would say nail down whether or not a Medigap insurance company will sell you a policy at a price you want to pay as the first thing to do. And if you can't find one, then end of game. But yeah, they vary. I'm not hearing anything.
Would you have to apply to these Medigap plans in order to determine whether or not they, sort of what kind of a deal they will offer you?
Yes. So the way to do that is go to Medicare.gov, or I imagine Shine can help. I don't know that really, but go to Medicare.gov or call 1-800-Medicare. Medicare.gov is the easiest one in my mind. So go there and you can get a whole list of all of the Medigap products in your community. So you can get that list. And they've got the phone numbers right there. You can apply online right there. So you can actually apply to several of them at the same time, and wait to get the applying does not mean you're committing to purchasing it. So you can go online and apply to Medigap for Medigap policies from several companies and then compare the results. Online, you can see sort of the average for that company for a premium, but you can't see what you specifically would have to pay. But you can look at the average that they charge. Now, if it's a low average, that might mean that they're really good at keeping their prices down, or it might mean that they're really good at not accepting anybody who's sick. So, it's hard to know what to make of that.
Florida retirees, state government choice of a number of plans. I'll assume that you cannot address that since the plans are different.
Can someone repeat that? I didn't.
Yeah, Florida retirees, people who retire from the state government in Florida, I need to hear more about this because I'm going to be one of those, have a number of plans that are specifically available to them.
There's a handful of insurance companies that they deal with the state offering certain coverage. Now, I don't know what the requirements are for that, how long you're employed and all of that. But we have these plans. Some are better than what's on the marketplace. Many are not.
Yeah, so this is just
But sir, I assume that you're not familiar with this. So I'll address it with Shine.
so we're assuming that you are probably not familiar with the specifics of these Florida state retiree programs.
That would be a correct assumption.
Okay.
But there is a little fact that you might want to sort of put in your hat, because I think I understand sort of the question behind your question, but the specifics you'll have to talk to Shine. But the question behind the question is, what are the plan? How good are the plans that are being offered for retirees, and what if you don't like them? And I want to go to a momentary little side rail of a story. New York City retirees, because they had compromised on wages for years, had a really generous retiree benefit where the city of New York was paying for Medigap for them, and they had terrific retiree health care with Medicare. And then I think 2 years ago, the city decided that they wanted to move everybody over to Medicare Advantage. That's not because the city was mean. That's because Medicare Advantage is paid 22 to 35% more per person. So they don't have to charge the city as much for the city to offer Medicare Advantage than when the city was offering Medigap to their retirees. So the city was just being fiduciary and moving people over to Medicare Advantage. Well, the retirees weren't happy about that because the retirees don't look at that as something, that's just generous. The retirees look at that understandably, as we worked for decades for the city, we took less wages because you promised us this robust retiree health plan. So don't mess with that. Remember my mother-in-law's face. Don't mess with that. And so the retirees in New York City, 250,000 of them, started marching in the streets, started railing, had street theater, had letters, petitions, campaigns, and they've won. They kept the city from moving them over to these inferior Medicare Advantage products. They won. There have been now 9 lawsuits between the retirees and the city, and the retirees have won every one of those lawsuits. Every one of the appeals, the whole process, they won every one. There's, I guess, still another 1 or 2 appeals pending, but the retirees have told me that they're confident they're going to win on those too. So if, the problem behind the problem you're raising, if indeed the retiree benefit program from the government agency you're talking about, or an employer that you were working for, anybody, if you find that they're trying to screw with your retiree insurance, you have power. You don't have to accept it. You have power, and use it.
Yeah, we're in Florida.
Yeah, I'm in Missouri.
Yeah, good point. All right, are there other questions?
Thank you, Dr. Weisbart.
Thank you, Dr. Weisbart.
Thanks.
All right, and there's no other questions in the chat.
I don't see any more in the chat. And again, we just can't thank you enough for giving us your expertise. So thank you. And I want to personally thank Barbara and Kim for the work that they did to bring this to happen, because oh my gosh, it's just so wonderful that we have you here because of them. I want to thank them.
Thank you, Kim.
Thank you again, Dr. Weisbart, Bart, and for those of you who are in the room, the Shine volunteers are here. Sure, they will be happy to answer more questions. I will make the recording available as soon as I figure out where I saved it. It's on my computer somewhere.
It's in the cloud.
Thanks again. I'm impressed with,
All right.
with your great questions. Nice to see all y'all.
Thank you so much.
Thank you.
Bye-bye.